Welcome back to Oncology for the Inquisitive Mind as we continue our journey through ASCO 2025. I'm Michael and that's Josh, and we are very, very happy to welcome back Dr. Janet Abrahm, who is a specialist in palliative care. Not something that we found a lot of these post-ASCO summaries include, so we're very excited to have Janet back. Just as a quick background, if you haven't listened to our previous interview with Janet, thoroughly recommend you do, but she is a professor of medicine at Harvard Medical School, a practicing or a former practicing medical oncologist, and an expert in palliative care. And she has over 20 years' experience in the forefront of palliative care at Dana-Farber Cancer Institute. And as if that wasn't enough, she's somehow found time to author 4 comprehensive books in supportive and palliative care. So, Janet, thank you so much for coming back and taking us through what you found interesting at ASCO in the area of palliative care.
I'm very happy to be back, and I want the listeners to also know about the website, because I know
Absolutely.
it's very difficult for people to read these days. So it's maybe you could put it in the chat or whatever, but it's simply my
Absolutely.
name, janetabram.com. And the way I organize this presentation will be around the 4 domains, if you will, of resources that we offer completely free, of course, on the website. So they involve pain and symptom management, communication with patients and caregivers, special topics, and then end of life and bereavement. So I tried to organize this update in those categories so it'll be clearer. I wish
Fantastic.
there were one big blockbuster. I think the New England Journal in June had published what might be the biggest blockbuster, but it was not presented at ASCO because it had already been presented at the GI meetings, which is that exercise actually prolongs life in patients with colon cancer. So those who are interested can read the article in the New England Journal in June. But that was a very exciting non-pharmacological finding, I thought. What did you guys think?
We
Yeah, it
thought it
was.
was brilliant.
Is that the Challenger? Was it
Mhm.
Challenge or Challenger trial? Like it's
The
absolute,
challenge study. Yeah.
like incredible stuff. I know it wasn't mentioned, but if you want to maybe talk to listeners a little bit more about sort of that trial, if you've got anything on that, if not, it's fine. They can go to your website and sort of talk about it. But it's I think you're right. It is groundbreaking because A, it's cheap. B, it's good for the
Yes.
person, and C, there's pretty much rarely a downside unless you fall and break your hip.
Well, actually, that is one of the caveats. One of the articles did talk about the fact that male patients who are on androgen deprivation therapies do have a higher chance of bone fractures.
Yeah,
So the
interesting.
idea would be that you do need to have specially tailored exercise therapy if you're going to do that. Now, I'm not
Yeah,
saying
fair
that
enough.
people who have colon cancer necessarily have osteopenia, but it's something in general to think about when you're trying to exercise if you have cancer. It's useful to check with your oncologist if you have a potential for having osteopenia from any of your treatments.
I remember something that was written in that article, or a comment relating to it, is that we authorize sort of cytotoxic chemotherapies on the basis of much less clear benefit for patients. So why would we not do this? So it definitely something that is simple and theoretically non-toxic to the patient. But speaking of toxicity, Janet, maybe we'll start with with your first section on pain and symptom management. And
Mhm.
a question that I'm sure I've certainly been asked it a ton. I'm sure you both have about cannabis
Yeah.
in oncology patients.
Well, luckily, ASCO has a guideline from 2024 about the use of cannabis in patients with cancer. And I recommend it to anybody who is interested in this area. Abrahm was the first author of that. There had been some controversy about whether there was negative survival effects in people on immune checkpoint inhibitors. An abstract 12081 talked about that. They actually found that from 666 patients enrolled from 2022 to 2024 with outcome data, they did not see any problem in terms of median overall survival. In fact, they might be highly longer in these patients. So those patients who were getting immune checkpoint inhibitors do not have to stop using cannabis if that has been helpful to them. For chemotherapy-induced nausea and vomiting, when all of the triple therapy recommendations have not been adequate, especially to control nausea, cannabis can be recommended for that. The most important thing there is that those guidelines aren't always adhered to, so that people are not getting, especially the dexamethasone part of the cocktail for the days that they need it, or the olanzapine part of the cocktail for the breast cancer patients when they need it. So it'd be really important for clinicians to review the recommended guidelines, or maybe have them, as we're lucky enough to have them hardwired into our chemo protocols. So at Dana-Farber, we're lucky enough to have the antiemetic protocol matched to the chemo protocol when the order set is created. The other thing about CBD in Abstract 12061, there was a randomized prospective double-blind placebo-controlled trial with locally advanced or metastatic lung cancer. And in many states of the U.S., you can get they have pharmacies and medical marijuana dispensers where they'll tell you how much THC or how much CBD is present in any product. This study was on a cannabis sativa extract that involved a lot of CBD, starting at 10 milligrams a day, with titration every 5 days until the patients reach their goal, or a maximum dose of 100 milligrams a day. That's important because the guideline notes that over 300 or more milligrams a day, there's a lot of toxicity involved with cannabis, which I'll mention in a moment. But anyway, these patients did not have to go as high as that. They only went as high as 100. There was a difference in mean pain scores in the CBD group compared to the placebo group. Quality of life analysis didn't show much difference, but dyspnea and insomnia were statistically helped. So if you can get purified, safe cannabis from a medicinal source, from a place that sells medicinal products, this can be recommended. At least it's safe. The problem, though, over 300 is the toxicities. What happens is that with overdose, people could get ataxia, they could fall, they can get paranoia or dizziness, they can get orthostatic hypotension. And the panelists discussing cannabis recommended that the electronic health record start recording cannabis use the way they record tobacco use, because they think it's very important for states where it's legal in the U.S. to do this. In the U.S., it's legal in 37 states and the District of Columbia for medicinal use, and 3 territories. It's only fully illegal in Idaho, Kansas, Nebraska, North Carolina, South Carolina, and Wyoming. So most of the country, patients can avail themselves of this. And they think that we should include the reasons that they're using it, like symptoms, versus they think that it's helping their cancer, which cannabis does not do. The source, the product, the formulation, the dose, like any drug, basically. But be careful about other side effects of medications. The contraindications are with warfarin, amiodarone, levothyroxine, clobazam, lamotrigine, and valproate. And again, you can read all this in the guideline. I'm just mentioning that they state this. Also, with stimulants like Adderall, patients could have decreased appetite. With metformin and Prilosec, you get increased diarrhea. And of course, there's worry if you use other medications that might have similar effects, like antipsychotics, opioids, benzos, antidepressants, antihistamines. You can get much more sedation. And interestingly, also Kava, melatonin, and St. John's wort, and psilocybin. All of those have increased motor vehicle accidents. As you can imagine, it's from going too slowly and not having a great reaction time, not going too quickly. Any thoughts or questions about cannabis? I recommend that everybody read the guideline. I think it's very comprehensive.
Yeah, I think it's a question, certainly in Australia, because I think, Josh, correct me if I'm wrong, but I think the access is a little bit more murky. It's not as heavily regulated, but people will frequently ask us, I know I've heard of so-and-so who had a good experience using medicinal cannabis, and it's something that's very commonly asked. So knowing a bit more about the potential pros and cons, I think, is very useful for anyone working in a place where it's more available.
That's why I think ASCO highlighted it, because we're being asked so much more frequently about to prescribe it now that you don't need a special card to do that.
Yeah, I think in Australia you need a specially registered clinicians to actually get access to it, and many of them are palliative care specialists. But
That's interesting.
certainly not just anyone can do it. I think next, Janet, one thing that caught my eye in terms of the list that you've provided us was a chemotherapy-induced peripheral neuropathy. I mean, speaking
Yes.
of things that are asked a lot about and are very frequent problems that we encounter in the clinic. And there was some mixed results from ASCO in this area, isn't it? It's sort of the story of our lives in this section.
Well, people were trying to use agents that have been shown to help treat chemotherapy-induced peripheral neuropathy to prevent it. The idea being if you could do it up front, maybe it would help. But Duloxetine, which minimally helps chemo-induced peripheral neuropathy, abstract 12010 was not found to be any better than placebo. However, the placebo response rate was enormous. They were all in the mid-60s. So whether you got 30 of Duloxetine, 60 of Duloxetine, or placebo, 66% of the patients, about between 66 and 68, felt improved chemo-induced peripheral neuropathy. And it's very confusing because adherence rates were low. 44% in the 30 milligram arm, 50% in the 60 milligram arm, 66% in the placebo arm. So who knows what was happening in that study? I can't tell you, but certainly it can't be recommended for treatment to prevent chemo-induced peripheral neuropathy. Now, I'm intrigued by the limb cooling story. I have been since the work of Dr. Michelle and Dr. Rand, in that people test limb cooling by having one hand and one foot subjected to the limb cooling, and the other one is the control. So a person is used as their own control, which is very helpful, I think, in this area. Now, the actual study that was reported did not show the effect of limb cooling, but when you look at the literature, the amount of cooling may not have been sufficient because they only cooled to 10 degrees. According to the abstract, it was normal was 25 degrees Celsius. The other was 10 degrees. But the one that was effective found that minus 20 to minus 30 degrees Celsius was actually the one that improves and prevents chemo-induced peripheral neuropathy. That was the RAND study. It's in supportive care of cancer in 2025. And the patients were getting Taxol 125 milligrams per meter squared. Similarly, in the Michelle study, they had ice on the hand. So I think the jury is out on this. I think if you're going to try cooling, it has to be cold enough. Now, they didn't report on the side effects of having it cooled, but it was tolerable. And the longer the time went, the better improvement there was. So after 6 cycles, the minus 20 to minus 30 was really showed a less of a development of functional deficits like ADLs, doing buttons, things like that. So much restricted toxicity in terms of functional and in terms of discomfort. And that's the real thing with I think with chemo-induced peripheral neuropathy is the functional problem. Using your phone, using your phone especially, or doing buttons, or doing anything that takes fine motor coordination if you're a sewer. So I think that oncologists need to keep pursuing this idea of trying to prevent the peripheral neuropathy because it has also falls in older people. If you can't feel your feet, there's a significantly high incidence of falls from CIPN. So I think this area is worth continuing to explore. And if you're going to use cool, make it cool enough. That would be my bottom line.
Yeah, quite interesting. And you've hit, given someone who does a fair bit of breast cancer, all of these things are very, very pertinent. Look,
I don't want to know about Ellen Xanatan for hot flashes.
Yeah, well, that was actually going to be the next question. So just before we get there, I wanted to know, you said they didn't talk about side effects. So a number of my patients, either, they can't tolerate the coldness of the, the gloves or the stockings because it's not comfortable. And it's not as if it's a 5-minute treatment. These are prolonged
15
treatments.
minutes,
Yeah, months upon months upon months, right? Was there anything in the data that talked about how many, like the completion rate, how many people, what the adherence was for using appropriate cooling levels?
I did not focus on that.
Just curious because, it's like scalp cooling. I mean, when we jump to hot flashes, it's sort of the same thing, 30.
Yeah. Let me see if I have.
Stay tuned. I'm just, the curly
that's
questions
fine.
because
No, that's important. I think it's important. The main reason for study withdrawal was intolerance to cooling. It was only 6 participants, though, out of 60 in the Michelle study where they put ice.
yeah,
So that was only 6.
so
That's, I guess, why
10%.
it didn't leap out to me. And again, if you're in a study, you're probably going to stick it out, if
Yeah,
you know what I
because you're
mean,
motivated.
as you're
It's the
motivated.
selection bias.
I think it is selection bias because I think
Yeah.
people who are in a study and know that they're going to get something cold, I think probably stuck it out.
Yeah, and I think you've hit my curiosity hat. But hot flashes, my prostate cancer patients all complain of it. My breast cancer patients all complain of it. And we've got fezolinetant here, which has been approved in Australia. And while it's a great drug, it's quite expensive and not sort
Oh,
of reimbursed. But I'd love to hear about this and sort of what they found with the hot flashes and how you can cure it.
well, I don't know if you
Maybe.
can cure it, but yeah, it's interesting that neurokinin 1 blockade does so many interesting things. Elezanitant is in the family of aprepitant and fosaprepitant. They're all neurokinin 1 inhibitors. Maybe they're different subsets of them, and neurokinin 1 is also involved with chemo-induced nausea and vomiting. It's involved with pain. It's a substance P receptor. So there are these multiple effects, and you wonder if the hypothalamus, which is what's regulating your temperature, is being affected by neurokinin 1 receptors in ways that animal studies haven't really identified yet. But there must be something to do with that mediator because that's your temperature regulator. So there's a central role, lots of places for the neurokinins, in the fourth ventricle for nausea and vomiting, and probably wherever your temperature regulation is. But this seemed to really help reduce in a 52-week randomized trial, OASIS 4. This was abstract 508. It evaluated a dual neurokinin 1 and 3 receptor antagonist in women. This was in women being treated for breast cancer. And they definitely had an improved decreased in their hot flashes. Side effects were similar to placebo. Limitations, patients were mostly white and they were female. We know that oxybutynin helps men with prostate cancer with their hot flashes. Maybe this agent will help as well. The other agents have significant side effects. You can't use paroxetine with tamoxifen. So it's really helpful to be able to have a different agent to use. And gabapentin has its own side effects. So I don't know how expensive this drug is going to be, but it sounds like it's helpful. Same problem with venlafaxine. It has a lot of contraindications in cancer patients, and it's been used in breast cancer patients at the low dose of 37, so that there isn't a withdrawal problem like there is with higher doses of venlafaxine. But to have, as I said, we can't use paroxetine with tamoxifen. And there's another one called fezolinetant. It's also a neurokinin inhibitor that has off-label use for the same thing. So I think the neurokinin 1 inhibitors are going to be important in general symptom reduction in patients being treated for a variety of cancers. They already seem to be important players, and we'll have to see how they play out.
Yeah, absolutely. And I think, Josh has mentioned it as well. Hot flushes in both breast and prostate populations, they're often so debilitating. So many prostate patients, they tolerate the rest of the drugs that we give them completely fine. But it's the hot flushes that really get them not annoyed, but not questioning their desire to continue with their therapies. And obviously a big thing that we've heard from one of our previous guests in the series is the possibility of stopping ADT for prostate cancer, for early prostate cancer, which is obviously a major goal in this area because it prevents a
Sure.
lot of these things. But if we can manage them better, then that's good.
Have you used the oxybutynin for it in your patients?
Not me myself. I
It's
personally
certainly
haven't really seen.
really bad ones, but it is
Yeah.
recommended, and it is, there is literature on it. I'd give it a try before
Mm.
the
Yeah,
brand
I've
new
used
stuff.
oxybutynin a fair bit before we had access to fezolinetant. I found the results could be quite hit or miss.
I see.
Depending who it's also the cohort of patients. If they're adherent, for a while we didn't have access to it because there was a shortage of supply. So that never helps. So yeah, look, it's sort of I think the current theme I've seen in clinicians that I've worked with, they've sort of moved to the neurokinin if they can
Yeah.
in the
Yeah.
first instance, yeah,
They have so few side effects. They're kind of amazing that way.
that's it. They're lovely.
I've used them for
Like,
tumor fevers too. That's why I think that there's something central in the temperature regulatory system that they're affecting that we just don't know yet. Because they also anecdotally work, as I said, for tumor fevers. The good news about those breast cancer patients who are getting all kinds of therapies is that local estrogen therapy has been shown to be safe, actually, finally. 578 shows that the vaginal estrogens that have been being prescribed for sexual health, for normal vaginal mucosa, turn out not to add any extra risk in breast cancer patients. So I think for quality of life, that's a really important finding for those patients who really wanted to use them but were afraid to. Even though their doctors had said, yes, it's probably safe, it's nice to have some data in this study. It was a retrospective study of 18,000 female breast cancer patients in the SEER registry. And so, if anything, there was a statistically significant increase in overall survival. We could talk about the quality of life issues there, as well as breast cancer specific survival. So, in the patients who use vaginal estrogen compared to those who didn't. So, there's really no question anymore that that's safe and that you can recommend that.
And it's nice to have that confirmed because, as you say, it is something that we say, oh, it's probably something, it's
Yeah.
probably safe, but it's nice to actually have something to point to. And especially given that a lot of the treatments that we use for these women are worsening the vaginal dryness and those sorts of symptoms. And then that's why they're reaching for these sorts of things.
Exactly.
Janet, the next thing I wanted to ask you about is something that I'm quite passionate about, which is communication
Yes.
with patients. I think it's something that can make a huge difference. And you've highlighted a study that looked at the effect of anxiety, depression, and grief of a condolence letter, which is,
Mhm.
I'll be honest, not something that I've seen a whole lot in regular practice. But depending on what you report, might be something that I need to add.
Yes, Abstract 1228 talked about the effect of a letter of condolence proposing a postmortem consultation to the relatives of cancer patients. And they looked at that offer, that letter, the effect on anxiety, depression, and grief. Now, it was very interesting. It was a multi-center randomized study of patients who died in the hospital, so you know the time to send it. And they either got the letter or didn't. Very few actually took them up on the offer of the consultation. But of the 102 who completed the questionnaire 3 months later, 92 6 months later, both at 3 months, both anxiety and depression were significantly lower in the people who got the letter. And at 6 months, that continued. The less grief after the patient's death, less current grief. At 6 months, the anxiety, depression continued to be significantly lower, as was grief at the patient's death. Only 5% had a postmortem consultation. I feel kind of vindicated because when I did oncology back at my VA practice in the 80s and 90s, we had a whole bereavement program automatically with the computer so that at 6 weeks after the death, because that's where the literature says is the appropriate time, we sent a letter about what to expect in the grief. We gave them tips. At holidays, we sent a letter of this may be a hard time for you. And certainly within a week or two after the patient's death, we just either called them or sent a card to say that from the practice. And this was automatically generated by our EHR, which was very primitive at the time, but at least we knew we could do that. And so this feels very sensible to me because there's literature about how abandoned after such close years of every week, every 2 week connection, the patients and the families feel that, there was a paper called All the Doctors Just Go by Holly Priggerson, who's an expert on complicated grief. So I think this all makes sense because it's all concordant data. that making a call, sending a simple letter could be so powerful. And it should be pretty easy with the electronic systems we have to generate these letters, and you can personalize them or not, or just sign them. What do you think?
Yeah, I think that that is something that has actually struck me. I've talked to a number of patients about the transition from active care to sort of symptom based end of life care. And in Australia, they're often two very distinct processes. And so there are, places where the standard practice is the oncologist basically stops seeing the patient when we're
Oh,
handing over to palliative care. And I'd say this to patients all the time. I really actually don't like that,
yeah.
because there is, exactly as you highlighted, that sense of abandonment when a doctor's been so involved in your care, and then all of a sudden they say, I don't really want much to do with you. And so I think this is an extension of that. And like you say, it should be simple with the electronic software that we have to automatically generate and send. I mean, we getting to automatically generating and sending patient letters to their primary doctors with AI and stuff these days. But it should be easy. But it's something that, whether it's in the context of being busy or just sort of moving on to the next patient, that it's very easy to forget the people that have gone and the
I can
families that are associated with them.
definitely see that if you have this systematic severing, we don't have that in the US, luckily.
Hmm.
Very often, the oncologist, certainly Dana-Farber, the oncologist routinely is the patient's hospice doctor. There is a hospice doctor too, because in the US, you have to have two people certify that the prognosis is 6 months or less if the disease takes its usual course. I have heard people in practice, in the community, don't have the time, they think, to be the hospice doctor. But there's actually an interesting abstract 12100 about telemedicine enabling synchronous medical oncology and home hospice visits. And this really definitely led to feelings of less abandonment and earlier hospice enrollment. I think that they really liked it. When the oncologist could be on the Zoom visit along with the palliative care team, I would imagine it would help the oncologist grief process too. Just saying that way you don't feel like you failed, you haven't abandoned your patient. You can see that they're getting the kind of care that they need even to the end of life. As you know, I've written about disenfranchised grief of the oncologist in my newsletter, and there's a paper coming out in a journal this month about it. And I really do feel that disenfranchised grief, we're not, meaning that nobody recognizes our grief when our patients are dying. I feel that that's an important unrecognized contributor to burnout and compassion fatigue, because we don't have a place to put it officially. And our practices don't always have grief services. It's like, especially if organizationally you are forced in a way to step out of the care of your patients as they're dying, I can't imagine how that would feel.
It's rough. I think I think that's probably the only way to say it. It's rough, and depending where you work, Michael. Some places I've worked at, there are those follow up phone calls. Some specialists do it, some don't. There's no sort of standardization, but especially in the transition to palliative care, the system in Australia unfortunately isn't built. I feel this is an excuse, but it's not
No,
built to sort of the clinics are all overburdened in the public systems. They're having extra patients, and I suspect that's part of it. It's not rationalizing it, but I think one thing I've been thinking of during this whole conversation is that in ASCO and ESMO, it's always about the new drugs. We always hear about this is the golden drug, but no one ever talks about the people that you're not going to save,
right?
right? No one actually goes, hey, maybe we should look at ways of making the journey, because it's not, as you said, you see the person every 2 weeks, you might see them for
Yeah,
7 years. Especially in
yeah,
breast cancer world, it's not uncommon, and then you're like,
right.
see you later. I once had one of my specialists I worked with and I was training who did not recognize her patient on the ward who was underneath the palliative care specialist team. It was really awkward. This was many years ago. And I went and said
Right.
hi and had a big chat, and she was absolutely
Yeah.
gorgeous lady. But I'm just like, oh, that
Oh,
is really, really rough. But I have one question, because I know you've got a busy day and you've got better things to do
oh,
than
sure,
chat
sure.
to us. But you've
No.
got one heading here: burnout is still pervasive.
Yes, yes.
And I wanted to dig a little bit deeper into that because you've talked about, the burnout of grief, but there's also the burnout of oncologists generally. There's the
Yeah.
workload. And I want to know, was there anything in that space that you thought was worthwhile mentioning?
I
Anything
appreciate
else?
that opportunity because it's heartbreaking to me. Jennifer Ligable talked about this. I think unfortunately, what ASCO's paper was about was making space for doing research as well as clinical work. I thought that was a little narrow in its focus. I mean, how many tens of thousands of oncologists are there clinically versus the academic ones? It was useful, I guess, for the academic oncologists, but for the general oncologists, I think that there needs to be more limitation and more understanding that personal life and personal meaning, according to Shanafelt, who knows the most about this, and also in industry, making space for doing something personally meaningful to you every week is one of the key drivers to prevent burnout. I mean, that's how Post-its were invented. For example, 3M let their engineers do that. They could work on any project they wanted that had nothing to do with what their job was in one day a week in their free time. And somebody invented a glue that stuck and didn't stick during that time, for example. But for us, it's a matter of having control over your family life, having control over your schedule, not, as you said, having clinics that are overburdened. And I think you have to align with the values, get more peer support, the kind of thing I'm talking about remembrance, being able as a group of oncologists to remember the patients who died and talk about it and have your grief acknowledged. That's a little piece of it. And I think the leadership needs to focus not so much on RVUs and productivity as the quality of your life and the ability for you to persist, because it's not good for them not to do that. I think there needs to be some organizational understanding about that. And I also think in oncology training, a little more on boundaries, perhaps. That's why I wrote about countertransference. Countertransference is when you are feeling either more positively or more negatively about a patient than you normally would. And if you don't recognize it, for example, the positive one especially, if they remind you of your aunt or your grandmother or somebody you really loved, you're going to do things that are above and beyond, and you're not even going to recognize that. One of my best teachers, Dr. Susan Block, said, if you're doing something different for a patient, ask yourself why. If you're avoiding somebody because they're a complainer, or they remind you of your high school, PE teacher who was horrible to you, and you don't ask them about their bowel regimen, and then they get admitted for diarrhea. I mean, that's the negative countertransference where you hate them. But for me, it was more dangerous, the positive. I was letting people do stuff or letting people call me, giving them my cell phone number, a total no-no, right? So I think that oncology practices could reinforce that our values involve taking very good care of patients and very good care of ourselves. Now, how are we as an oncology practice or a group of practices going to manifest that? And how are we going to give positive reinforcement for boundary setting and for making sure that, as someone said, what's important that I come out every week, not that the paper comes out every week. We deserve that, but we need to go to the leadership and explain that the 2023 survey was even worse. It was even like 59%. Now, again, it was people who answered the survey, but it hadn't gone down any. The one reported at ASCO was around 40% burnout. That's huge. I think that's huge. And 40% didn't have good professional satisfaction. I mean, that's a huge number of our colleagues. So I would hope that people would advocate for leadership to come around what are our values, how are we going to operationalize them so that we feel professionally satisfied and taken care of and protected, because we work so very hard and our work is so very hard.
I don't think anyone could have said it better. It's something that I think the field as a whole is actually very bad at, is taking care of ourselves, and it's definitely something that we can improve. There is so much more that we could talk about. ASCO 2025 in supportive care, Janet, but we know that you've got a full day ahead. If you do want to, explore these areas more, we'll just direct you back to Janet's website. That's www.janetabram.com. And there's plenty of fantastic content there if stuff that's been discussed today has piqued your interest. But thank you so much for coming on, Janet. We really appreciate it, and we look forward to getting your wisdom again in the future.
It's been a pleasure. Thank you for the opportunity.
Thanks, Janet. Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you like this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.